Lovely to be with you. It's funny just doing this from home and just me, but then Andy has just explained that there's going to be up to over 1,200 of you logging in. So welcome. My name is Emma Vardy. I'm a consultant geriatrician. I work at Salford Royal Hospital. I'm also the clinical dementia lead for Salford Care Organisation and involved in regional work across Greater Manchester. And one of my particular interests is Delirium. And today is World Delirium Awareness Day 2021. So if you want to tweet about this, I've added the hashtag, and that's my Twitter handle if you want to sort of get in touch afterwards. So quite a few things. I'm just trying to move my slides on and they don't seem to want to. Yes, okay. So I'm going to cover quite a lot from some of the basics around delirium to putting things into context and explaining what we've been doing in Greater Manchester. And you'll need to kind of consider how it might apply to your locality. So some of the background, some of the context, I'm going to cover, I'm going to assume that varying degrees of knowledge. So I'm going to cover some delirium facts around diagnosis and management. I'm going to talk about some work that we've been doing in Greater Manchester around a community delirium pathway, because up until now, most of the work has been done in the hospital inpatient setting. Talk about the impact of COVID-19 around delirium and then round things up. So I was going to potentially try and show you a short film, but I've just had a test and the technology I don't think is going to play ball. And I also want to use the time effectively. So I'm sure that we'll be able to share some of these slides. I don't know how that works, Andy, but this is a link to one of a series of 4 short films that Yorkshire and Humber Strategic Clinical Network produced around delirium. And Grace's story is around a lady living in a residential type care. So I would encourage you to take the time afterwards to have a look at some of those films, because they're really good and lots of learning points around them. To give some further context, I actually looked up prior to delivering this talk, was there anything out there around paramedic ambulance service assessment of delirium? And the only thing which isn't fully paramedic focus, but was the closest thing I could find, was around this study from, I think it was from Canada, around emergency medical service nursing and physician providers' perspectives on delirium identification and management. And some of the conclusions they came to was that it's frequently encountered within the emergency medical services, and it did include ambulance services, that many don't employ clear diagnostic strategies, and that's really important, as you'll see, and that staff also have varying levels of comfort in terms of managing delirium. And I think that again reflects my and many others' experience of delirium. Just moving on, if I can. Okay, so again, some Greater Manchester context. There's a regional programme of work called Dementia United, and that's been about improving the quality of care, management, assessment, people's lived experience of dementia in Greater Manchester. And delirium was something that was added in partway through the programme because it was something that was deemed important to focus on in terms of providing a comprehensive programme around making Greater Manchester one of the best places to live with dementia in the world is the aim. And actually Manchester has achieved that in many ways, and I think it's ranked 3rd across the world in terms of cities, in terms of various metrics. It was a piece of work that was done, an international piece of work, but it is important, but not just for people with dementia. Moving my slides on, which hopefully I'll be able to do. And as part of the work, we've held events each World Delirium Awareness Day, and I can't remember, I think we're the 4th or fourth year now. And at one of those events, we engaged, we had various people who attended, who were stakeholders in different services. So health and social care, people with dementia, carers, care home staff. I don't think we ended up, I think it was not last year, but the year before, we did have our first paramedics starting to attend. But some of the, I think these standards would apply to improving delirium assessment and care, and some particular ones that stand out that I think ambulance services have a real role to play is every organisation, acute community, and I would include your services in that, should have a standardised pathway for assessment and management of delirium. I'm not sure at the moment that the scripts that emergency services use include questions specifically around delirium, or where the presentation is just delirium. So maybe that's something to consider moving forward. And the other aspect is delirium diagnosis should be conveyed at all transitions of care. So that includes yourselves. Picking delirium up as early as possible is really important, as you'll see, in terms of early detection and starting treatment early. I'll move on to the next slide. I think there's just a little bit of a delay. So this just shows you quite the prevalence, and I guess staff who are working in Greater Manchester, these figures will make more sense. But this is year on year, people admitted to hospital, non-elective admissions, where they had a delirium. And you can see that year on year, the numbers have been going up, the numbers are high. Then I don't think they're going up because there's actually more delirium out there. It's because we're getting better at detecting delirium and assessing for it. And those who work in Greater Manchester will be able to compare some of those figures based on the size of the organisation. I work at Salford, so it's nice to see that Salford is rising high. Yeah, I think these figures do reflect the fact that knowledge base of a number of staff involved in assessing patients when they're admitted to hospital has overall improved. So just move on to the next slide, if I can. And I'll be patient about it. Sorry about this slight delay. Okay, and again, this is just a graphical representation showing year-on-year improvement in, as I say, likely delirium case detection as opposed to actual increase incidence of delirium. But the thing to say about this is that I know even in Salford, we screen only a proportion of the people that should be assessed for delirium. So these figures and bars are very likely a significant underestimate of actually how much delirium there is not in non-elective admissions. So what is delirium? Well, I think there's two key features. It's acute and it's fluctuating. There's a couple of other features that are a bit more difficult to detect, and I'll explain in a bit more detail. One of them is inattention. So that means the person has difficulty in concentrating and focusing on the conversation. So a test for that would be the months of the year backwards, and whether they are able to do that without missing months out, or counting backwards from 20 down to 1. Disorganized thinking is a bit more difficult to describe and to elicit, but what that means in practice is that the person will flit from topic to topic, seemingly in a disjointed way. I think disorganized thinking is something that you probably need to see and look out for, and it's the area that I think most people find really difficult to define and detect. These are key features of the absolute, I guess, platinum standard assessment for delirium, the confusion and assessment method. And it's for, I think that the reason that things like disorganized thinking is difficult to detect, that it's more difficult to put into practice, and there is a training manual online through the HELP website. It was developed in America by Sharon Inouye, but I'm going to show you some well validated, well used tools that are easier to grasp and to implement. The other feature I should have mentioned is that it's due to an underlying physical cause, and there's a long list, which again we'll come on to. So why is it important? Why is it important to detect? Well, I guess the main thing is it's really distressing for people who experience it, for families, for staff looking after people with delirium. When people are there, there's a high risk of hospital admission. There's an increased length of stay in hospital. I put some figures that we had at the start of the project that we're doing in Salford. And I can't remember those the updated figures off the top of my head, but it's longer than people without delirium. There's a high risk of falls and other harms, such as pressure sores. So where organisations report high rates of falls, the query is actually what's their rate of delirium, because there's a significant link between the two. It's life-threatening. So in hospital, 1 in 5 will be dead in a month. That's similar mortality rates to sepsis, but I don't think it assumes that delirium assumes the same importance in people's minds. And actually, it's a higher mortality rate, I'm told by cardiologists, than myocardial infarction. That's probably due to the improved care and detection of myocardial infarction, but also reflecting problems with detecting and managing delirium. You are more likely to go on to develop a dementia in the future. There's evidence it speeds up the rate of decline in dementia. So if you have Alzheimer's disease and you have a delirium on top, your rate of decline in terms of your memory and cognition, it doubles the rate of decline. People who experience delirium are more likely to go into care, into long-term 24-hour care, and it's really common, yet it's under-recognised. So you may think, well, surely if anybody is unwell, then, you know, they would get a delirium. So isn't delirium just a marker of sickness? Well, yes, but if you compare, so this is an example, I pinched the slide from a geriatrician colleague based in Birmingham, Tom Jackson. So you have 2 patients, Mary and Martha. Both have pneumonia. Mary has a delirium, Martha doesn't. But Mary is much more likely to die or to go on to develop dementia because of the fact that she's had a delirium. So it confers a particularly bad prognosis. It's really common. We have better figures for in hospital. So it's said that it affects 1 in 8 acute hospital inpatients, but I think that very much is dependent on what sort of services that hospital has. So there are particularly high rates on older people's medical wards, post-surgery, particularly hip fracture, around 50% of intensive care unit patients. So that's what I mean about, you know, it can happen in younger people if they are ill enough. It also happens in children, so paediatric intensive care unit patients. Up to 30% of admissions to the emergency department will have a delirium. The rate is high in palliative care units and end of life. And I'm just showing you a couple of slides. Sorry, I'll show you in a moment. Sorry, I'm leaping ahead of myself. So there are a number of risk factors that increase your risk of developing a delirium. So the ones you'll be familiar with and what I've talked about already are with increasing age, with a background of well, either diagnosed or undiagnosed dementia. So the diagnosis may not be known, but actually it may emerge that the person actually had a developing dementia prior to the delirium. Comorbidity, post-surgery including hip fracture, being on multiple medications, and also severe illness. I'm just showing you a couple of other slides because hopefully it might make you reflect on when you are assessing and bringing other groups of patients into hospital, how often do you assess for delirium and how often do you see delirium? In fact, thinking about some of the patients that you will see, how often are you looking for it and how much might you be missing? So this is, I've given presentations to a number of staff groups, and I think without fail, where the research exists, the outcomes for delirium with those conditions compared to without delirium are much poorer. So, for example, stroke incidence is around 13 to 48%. Prognosis is much poorer, increased rates of death, longer hospitalisation, greater degree of dependence after discharge. Prognosis is worse, longer it persists, and it almost 5 times higher of inpatient and 1-year mortality. So those pretty stark figures. Care homes, it may not surprise you, but again, there's very little work that's actually been done in care homes. So one study, a Dutch study, rates of 8 to 9% of residents, whereas an Italian study around 36%. As I'll explain shortly, with COVID, those rates having likely increased. So World Delirium Awareness Day is just always a great hook to hang and opportunity used to develop training and resources. So these are some the structure and the framework that we sketched out at one of those days. So including feedback from the people attending those days, the priorities were hospital pathways, developing community pathways, and education for staff and carers for people with dementia. And this was the flow chart that was developed off the back of that. So it includes history of any change in mental status or new confusion that might be picked up either through the single question in delirium. Is the person more confused than normal, or are they more drowsy than normal? Then if the answer is yes, going on to do the 4AT assessment for delirium. Again, then if a probable delirium is suspected with a score of 4 or more, then going on to assessment for using the time management bundle, and then management, etc., would ensue. And also decision making at those stages as to whether there are any red flags, whether the person needs hospital admission, or whether there are services available and they can be cared for at home. This is the 4AT, which I'm hoping many of you might be familiar with. And there's a picture of Alistair McCulloch, who's a good friend of mine, but also an international expert in delirium who developed the 4AT. And it consists of 4 parts. So the first is through observation, so alertness level. And the beauty of this is that anybody can be assessed, even people who have speech problems due to things like stroke. So depending on the alertness level, the person would acquire a certain score. AMT4 is just asking the person age, date of birth, place, and current year. And based on number of mistakes the person makes, or if they're not testable, they would again achieve a certain score. Attention is asking the person, can they recite the months of the year backwards, starting with December? And I always kind of like lead the person in and will say, can you recite the months of the year backwards, going backwards from December? So for example, December, November, and keep going. In some languages, their months of the year might be difficult, so 20 down to 1 might be appropriate. Also, it might be particularly difficult for somebody with dementia who doesn't have a delirium. So I sometimes do revert to kind of going 20 down to 1 and using sort of an analogous scoring system, but months of the year for the majority of people will be fine. And then the fourth aspect is acute change or fluctuating cause. Some people, I think, become a little underconfident at this stage and think, well, I don't know, so therefore, I won't complete all of the 418, I'll just leave that blank. It's basically really important to try and find that out from carers. And if you know the answer, and when if you have evidence that there has been an acute change, score them as 4. If you have no evidence, then to score them as 0. Or if you're absolutely uncertain, then I guess it's a bit of a judgment call, but I have been advised that you would at that stage score the person as 0. So important to try and get that background history if you can. Causes, this is a really nice mnemonic to try and help remember them, and will again help you work out whether, depending on what community services you have and whether the person can be supported at home, whether there's any red flags, whether the person needs admission, whether there's something that's immediately treatable. So P is for pain, and that will include things like urinary retention. I saw a lady who was transferred to the ward who was very agitated on transfer. She'd been given lorazepam to calm her, and on arrival she had a palp. She was holding her stomach, and we assessed her. She had a palpable bladder up to umbilicus, and she drained 2 litres of urine. So actually that was the cause, and she settled very nicely, and actually she had constipation causing urinary retention. The issue with urinary retention is putting a catheter in itself there is a link with delirium, but in the case of retention, a catheter may be necessary, but the key is keep it in for as short a time as possible. I put cardiac because not to forget that myocardial infarction can sometimes present with delirium. I've had a gentleman, and delirium was all they presented with, and they had an ECG as part of their assessment and a hydroponin. I had another lady on an inpatient ward who had dementia, and she was given lorazepam again to calm her. And actually, kind of on further sort of assessment, some kind of non-verbal cues, and asking her about pain, it turned out she was getting some angina pain, and doing an ECG and doing a troponin, she actually had cardiac changes. So the treatment was not just to sedate her, it was to give her some analgesia. I is for infection, any kind of infection, and I'd include COVID in that list. A word of caution, so quite often I see many clinicians, health and social care workers talk about delirium as if it equates to a urinary tract infection. And whilst in some cases, urinary tract infection may be the cause, it's certainly not the case in all. And we have some resources in the community delirium toolkit on the Dementia United website that links in with resources around assessment for urinary tract infection. But some rules of thumb: don't rely on a urine dipstick, and ask about symptoms of urinary tract infection in addition to the symptom of new confusion delirium. Intracerebral, so an intracerebral bleed or ischemic stroke. Nutrition, so poor oral intake, dehydration, poor fluid intake. C for constipation, and it might sound innocuous, but in older people, that a relatively small insult such as that can precipitate a delirium. M for medication, so new medications. Some common culprits are things like opiates or steroids. Withdrawal of benzodiazepines in somebody who is already been taking benzodiazepines long term can cause delirium. And the other thing to just sort of not miss is alcohol withdrawal. Metabolic can be anything, so low sodiums, high calciums, low calciums, etc. And environment, so whether if there's been sleep disturbance. I had a gentleman when I was working in the northeast who, when I arrived on the ward, was very, very agitated. He did have a diagnosis of dementia, and actually delving into his background, it'd been Christmas. He'd been moved from one room to the usual room that he went to sleep in to make room for some family members, and became and that precipitated a delirium. So once we knew that, we were able to adjust things and support him going home to be with his family. Moving places, so being admitted to hospital in itself, moving wards, particularly in the middle of the night, is deliriumogenic. And sensory impairment, so poor eyesight, poor hearing, making sure that hearing aid batteries are working, that the person has their glasses. And important when that person comes into hospital as well. I know some family members get concerned about hearing aids going missing, but being on the other side, having somebody who can't hear, hearing impairment being a risk factor for developing or persistent delirium, really important to have working hearing aids. Diagnosis, so history is vitally important, and that collateral, asking about things like any other features such as hallucinations. Visual hallucinations can occur in a delirium, and they can be really, really frightening and cause quite a lot of paranoia and agitation. Vital signs, so the News 2 just in the last couple of years had new confusion added to it, and there is guidance on the Royal College of Physicians website which suggests using the single question in delirium followed by the 4AT to assess that. Physical examination, so that's tailored depending on on the particular scenario and the cause, but as a minimum, looking for any causes of infection, assessing for constipation, looking for a palpable bladder for urinary retention, dehydration, neurological examination, and the detail of that will depend on history and other features. There's a couple of other features that you might have noticed thinking back when you've seen some patients called carphology and floccillation, and that refers to people picking at bed sheets or plucking at thin air, and that there's a particular link with that being a feature of delirium, and actually it confers a particularly bad prognosis if you do see it. And then a cognitive assessment tool, so the one I would recommend would be the 4AT. I think it's important at this stage to just mention some delirium differentials. So we often mention the 3Ds, so delirium, depression, and dementia. So some of the distinguishing features are dementia, is chronic, might be more gradual onset in the case of Alzheimer's disease, but certainly, evolves over sort of months, whereas delirium is hours to days. Depression, I do apologise. I'm just going to take time out for a second. The joys of child bedtime at the same time. What I was just saying. So yes, the 3D, so dementia, depression can commonly be hyperactive delirium, the more withdrawn, quieter, apathetic delirium, where people might be drowsy as well, can sometimes be mistaken for depression. And that's where the history, the assessment are really important, and the 4AT as well. It can be a stroke mimic. So I, having worked on the inpatient old people's medical wards, will not infrequently have somebody transferred from the stroke unit who was assessed as being a potential stroke, but actually stroke has been excluded, and actually it's felt to be a delirium. And the fourth thing, I would say there's a fourth D, and it's something that's emerged through assessment of the community delirium toolkit, and that's dying. And I think it's really important to know about how, if a person's deteriorated, the trajectory of that deterioration. So a couple of examples just to kind of illustrate that. So there was a lady who was referred to one of the community teams in Salford. She had Down syndrome and a history of Alzheimer's dementia, and was referred to the team as needing end-of-life care. It emerged that actually she had deteriorated over the last couple of weeks. So whilst she was at that time spending much of her time in bed, not eating or drinking very much, 2 weeks ago she'd been walking around with her brother, and it was only on kind of eliciting that piece of information, doing some further assessment, she was admitted to hospital, and she was found to be septic, and recovered and did very well. And it's something that we've had reported by various other community teams, that by looking for delirium, considering delirium, you might have a reversible situation on your hands, and that can be quite a difficult judgment call sometimes, but background and history and context are really important. Investigations, so blood tests looking for underlying causes that we've talked about before. Glucose, so making sure you're not dealing with hypoglycemia or poorly controlled high blood sugars. Urine dipstick with those cautions that I'd mentioned before. Some of these other tests would be in hospital if indicated, so blood cultures, blood gases, chest X-ray if indicated, ECG to rule out potential cardiac cause, and a CT head. And somebody just asked me this today, when would you consider a CT head? And this is where some of the red flags come in. So my advice, and this is also in various guidelines, would be if there's focal neurology, if the person has had a fall or and a head injury that's known about or can't be excluded, or if you haven't found another cause as a result of all your other investigations, or if the delirium persists and there's no other cause identified. And the other point to say, if the person's on anticoagulation, that brain imaging should be urgent. This is something called the Time Bundle, which the Health Improvement Scotland developed, and it's a prompt pathway to look for triggers, investigations, institute and devise a management plan, and also engage, explain, and that's a really important aspect, to explain to relatives, to carers, to the person themselves what is happening, and that it is a delirium, it is treatable, and that many cases will make a full recovery. Management is, again, it's quite straightforward. That's why I like delirium. None of these are sort of weird and wonderful causes. So identifying and treating the underlying causes such as infection, constipation, pain, reviewing medication, see if anything new's been started or if anything can be stopped. Supportive care, so observing the person, making sure they're eating enough and drinking enough, considering whether their environment should be altered and whether they go into hospital. And again, that will depend on what support services there are available to support that person at home. But if they're in hospital, reorientating the person, explaining to families what's happening, and involving families. And that's been one really difficult through the COVID pandemic, not being able to have family visitors. Verbal and non-verbal de-escalation techniques, reassuring the person if they're having frightening hallucinations that things aren't real, and providing information. I put the intranet because we have some resources on our intranet at Salford. We have a Greater Manchester Delirium Community Toolkit that we've developed. All of these resources are available on the Dementia United website that we've been piloting during the pandemic. The starting points were a team in Scotland had developed a community delirium pathway. We engaged people with dementia and their carers and professionals from a variety of disciplines. And we actually had a call from community teams at the start of the pandemic to fast track this because of pressures on hospital beds, but also, and limitations in terms of visiting, but also because actually it was something that we've been thinking about already, and it was just that the need presented itself a bit sooner. So we did complete the production of these resources. We involved various different stakeholders, including North West Ambulance Service. It's all been about raising awareness, reducing variation in detection rates, and improving prognosis and outcomes. We raise awareness around the SQUID, the single question in delirium, and the 4AT, and have included in that toolkit any resources that might be needed to assess, manage and care for a person with delirium in the community, and included in a delirium information leaflet for families and for carers and relatives. The timeframes, these are based on national timeframes for community response, but also based on Health Improvement Scotland's guidance that initial assessment should be rapid, the 4AT and starting to look for triggers, and then the rest of the assessment might be completed over the course of a couple of days. We've included various resources that teams might need to look for triggers, and various guidance around investigations and other resources that might be needed. Many teams asked, whether bloods would always be needed. And I think that's been an interesting area, because in hospital, we would automatically do those blood tests. In community, there's been varying ability of community teams to be able to do those. I think all teams have increased the number of blood tests that they've been doing because they've realised that difficult to find out the cause or the multitude of causes, because in many cases it wouldn't just be one cause. But sometimes, if it's been the person has had delirium before due to constipation, for example, and they haven't opened their bowels for a few days and the cause is really obvious, then you wouldn't need to necessarily do other tests. So we've been learning as we go. The leaflet has been really, really well received, and we've had some excellent feedback. Again, it's downloadable from the Dementia United website. There's a long version and a short version. We're really happy to share these. We'd ask people, if they do plan to use them, to just let us know and just share any feedback. But one of the things on it was a bit of we set ourselves an ambitious target to talk about prevention, caring for the person with delirium, and things to look out for in the future. But we also included a part of it about what has caused the delirium this time in that person, so that that would be available for the future, and helping families understand that particular person's delirium. In terms of Greater Manchester, for those of you working in that area, these are the teams that have become involved. Some of them have not been able to continue in terms of the pilot of the community delirium toolkit because of other pressures in terms of COVID oximetry at home and staff being reallocated to other services. But we've had overall some very, very good engagement, and the teams that have used it have found it excellent. And of course, we've worked with NWAS as well. COVID has really thrown up some interesting issues around delirium, but also put it in the spotlight. And I'm aware that I'm running out a bit of time. But just to say that early on, symptom trackers for COVID flagged up that confusion, altered consciousness was a really common symptom in delirium, even higher prevalence than loss of taste or smell. And so as a result of that, I worked with the British Geriatrics Society as chair of the Dementia Related Disorders Special Interest Group. And I was also hearing at the very start of the pandemic that there was that people were noticing that link between delirium and COVID, and sometimes in older people it would be the only symptom. So I and others collated and publications and worked with Public Health England such that delirium was added as another condition which should prompt, particularly in older people or those with cognitive impairment, a test for COVID. And it reached the headlines as well, which was great to see, and the awareness was raised. And the other aspect is to say that much like, as I've explained, the outcomes in delirium in the context of various other illnesses, COVID is no different. So delirium in the context of COVID, the mortality rate in hospital is very high, 72% with delirium compared to 32% for those without. It's been an opportunity to really capitalise on the other resources that we have around digital and incorporating delirium assessment in any electronic patient records, linking in with frailty agendas, conversations around terminology as well. Some other specialties in medicine might not always use the phrase delirium, and it's opened up some good conversations around that. And what we've noticed is a ripple effect as well, that other people, once they've heard about the work, we've engaged with them, so GPs, primary care, mental health, learning difficulties, apps that have been used in care homes to look for COVID symptoms, and also the auxiliary home pathways as well. The pilot evaluation, what we've heard back is the toolkit, the community delirium toolkit, very easy to use. The leaflet's been very useful, and we found that we managed to keep 70% of people on the pathway at home, which is, I think, been a real positive and a proof of concept. So what's next? Well, we're in Greater Manchester. We're completing that evaluation. We're continuing to work with partners, including NWAS, and Sarah Harris, who asked me to do this talk, is doing an excellent quality improvement project around raising awareness, of which this webinar is part, across ambulance services. We're going to be translating the information leaflet and also have a talking leaflet. The feedback from some communities, minority ethnic communities, is that actually written information might not be as useful as kind of spoken information. And we're also developing and pulling together all our resources around hospital delirium assessment into a toolkit using the same principles. So to round up, delirium is common. Identification is absolutely key, and identification not just at the front door of hospital, but before the person comes to hospital in their own home is really important. my sort of utopia would be that on admission to hospital at handover from ambulance teams would be aware from you know, crossing that threshold of whether what the person's 4AT score is, using the squid and the 4AT followed by the 4AT, using the pinch me mnemonic to look for causes and just being aware of the red flags. Community team working is increasingly important, and I would encourage you, you know, to find out, you know, are community teams looking at, you know, can they care for delirium? If they aren't, might they be interested in picking up the community delirium toolkit? And at the moment, considering COVID, because it is a potential differential in the causes. To acknowledge so many people have been involved in this work, definitely not just me, the team, particularly Helen Pratt and the team from Dementia United, many members of delirium steering groups. Actually, this has been work that's been going on over years, and this evening, thanks to Sarah for inviting me to talk. And if you want to look up the resources, this is the Dementia United website, and this is just a screenshot of, there's links, or everything is there, the toolkit, hospital program education resources. There's also films as well that are uploaded there. And so thank you, and happy to take, I think I've kept perfectly to time, happy to take any questions, and if you're further interested, get in touch either via Sarah and the team, or that's my email address, and I'll stop sharing at that point.